Hello, welcome to Pediatrics Theory 334, National University. This is for cohort 65, and this lecture will be taped so that you can watch it during a holiday week at your own convenience. If you have questions in regard to things in the lecture, you can email me at ann.holler@natuniv.edu or Erica Scarborough at with the same email at NATUNIV. You should have heard from Professor Scarborough with an introductory note about the beginning of the class. Since it started during a holiday week, we thought that it would help you to have the flexibility to watch the lectures at your leisure or your convenience. But if you have questions, please don't hesitate to reach out to us. We will get back to you. Our course is going to be a hybrid course with a combination of Zoom meetings and in-person lectures on campus at Rancho Bernardo. Room 118 is our dedicated room, so any lectures on campus will occur there. So you will have a first live lecture with Professor Scarborough next week on the 29th, I believe, Tuesday of November. And then I will see you on Zoom again, but live on December 6th. On December 12th, there will be a clinical skills day held on campus, and from 8 to 12:30 on Monday, the 12th of December. On our regular lecture day, December 13th, we will meet live on campus. Our campus requirement is that the theory class have in-person lecture once a month. So that's how we'll meet that requirement. Then we'll be off for the holidays and begin again on January 3rd. So you have a course comp. It should outline the details that we talked about with your assignments for Prep U, as well as the lectures, chapters. And then the other piece is presentations. You're all used to giving presentations, and the rubric is available in the syllabus. The lecture presentation topics are listed in the course comp. There will be 10 presentations, and because there are 39 of you in class, the expectation is that there are 9 groups of 4 and 1 group of 3. So I think that works out. And if there's any difficulty about that, we can sort it out in week 2 lecture live with Professor Scarborough. Our expectation is that you will decide what group you want to be in and what topic, and then email Professor Scarborough what your choice is. The choices will be first come, first served. We like to have all of the presentations assigned by the end of the first week, but it will be different this time because we're not in person for our first lecture. So at the beginning of class in week 2, please make your choices known to Professor Scarborough. She'll get back to you and feedback to you on whether that's acceptable or whether you might have to choose a different topic. So I think those are just kind of the early things that we want to take care of so that you understand what's to come. Presentations begin on week 3 and run through week 7. So please make those choices, picking your groups as you desire. So this is a little unusual, but we hadn't expected to start during a holiday week. So we know it's kind of difficult for many. And so we hope this is going to be a flexible way to start this course. We're beginning with 3 chapters on development, child development and growth of young children. And we'll continue next week in the same pattern with older school-aged and pre-adolescent, adolescent children. So the important thing to know is The framework of these slides in the first 2 weeks are pretty consistent as using a pattern of looking at growth and development in a certain way. It's important to realize that many of the skills that you already have with Med-Surg are present, but now we're taking a pediatric twist. So child development and the attainment of skills at certain levels are pretty consistent across the board. The theorists will talk about, even though they happened or described these theories years ago, they're still quite relevant because human beings grow in a certain way and certain patterns can be expected. It's important for you when you look at the developmental levels and the maturity of expectation that you get them really firm in your head. So some things, there are charts, and it probably will help you to memorize them quite seriously, because when you're making assessments in pediatrics, you're always making reference to the developmental level, maturity, and growth of the child. So knowing the normal expectations allows you to make comparisons on site and will facilitate your assessments. So keep that in mind and realize there are some things you just kind of hardcore need to know. Vaccine schedules are another thing, infectious diseases that we'll be talking about. There'll be certain elements that you just really need to know. So expect that as part of your studying, there are certain things that you really want to commit to memory. The developmentalists as well when we get into those. So I'm just laying that out so that you realize what's expected. We're going to go ahead and start this lecture, and you can see this cute little baby in front of us looking at you, kind of a little cross-eyed, which is kind of typical for the age of this infant, and we'll talk about that later. But let's go ahead and start. When we talk about growth and development, we look at the changes of children. We're going to look at the increase in physical size. And remember that certain times of the growth cycle will be faster than others, but there is a range that we would expect. And so we see the amount of growth that goes on. So growth is the actual physical size of the child. Development talks about the sequential process of skill attainment. So infants are going to go from reflexive actions to actually attaining skill and making purposeful movements. Maturation comes with increased functionality of the body systems and the overall developmental skills. So realize that those are basic definitions of things when we're talking about developmental changes. If you look here on the right, you can see a growth chart. There are a number of standardized growth charts that are used for children. You usually find them right in the beginning of their charts. And every time a child makes a visit to a facility where they have a record or where one becomes established, these measurements are taken, irregardless of the reason they came, whether it was, episodic or routine or well care. So the bottom line basics that we want to measure are the weight, the length, and for infants, the head circumference. Once the fontanelles close, then head circumference would not be measured because we don't have expectations for change. When we look at how to use this chart, there are different percentiles, and so that when we're following a child from visit to visit, we would expect an expectation that they will stay within a certain range of a percentile where they may have started. It will change and vary, but we should see kind of the same general trends in an upward way. When we see children fall off the chart or suddenly have a big change in those percentiles, we should be looking for other reasons. Something else is happening. So we want to plot them on the standardized growth chart. Parents are always delighted to know about the size and length of their baby. And so particularly the younger ones, they want to know. And look at the child, at the whole child, but realize that these measurements will give us a clue as to the direction of the growth. So we'll talk later about how we take those measurements, but just come to rely on the growth charts. You see this one is colored pink because it's for girls. They have ones in blue for boys. So it's based on their DNA, because we know that males and females grow at different rates. And so they're compared male to male, female to female. There are also other growth charts that are available for children with chronic disorders. Some syndromes have varying growth expectations. And so rather than compare them to the average child without that condition, they're put in a comparison with other children that have those same characteristics. So the measurements are usually approximate, but we would expect if we see a child in a 30th percentile that they may hang out close to, between 20 and 40% as they gradually grow. If they're in a higher one, the same thing kind of occurs. Remember, part of it is going to be genetics, is the child from very tall family, very short family, so that the child may be taking on those characteristics. Or are there other changes that may be occurring in their growth? Significant deviations from previous percentiles will indicate, obviously, the need for further assessment. And there are examples listed here of specialized growth charts. So when we look at infant growth, these are kind of standard things to expect. The weight for a child, average weight is 7.5 pounds at birth. They generally will double their birth weight between 4 to 6 months and triple it by a year. Average length of a child is 20 inches at birth, and their height will increase by about 50% in the first year. Head circumference is usually 13.5 inches at birth, and that will increase by about 10 centimeters by a year. So remember, their head size is large, disproportionate to their body size at birth. They'll become more proportional as they grow. When we're assessing developmental milestones, the things we do in our intake and conversations with caregivers is to talk to them about what the child is doing. And parents are always pretty interested in sharing with you what's new or different from the last time they were seen. Observing the skill that the parent talks about is a great opportunity to see just whether the child has made that attainment or to what degree. And that's part of descriptors that you would put in your assessment. There are a variety of screening tools that can be used and for different ages and stages. So many times your facility will have established which of those tools they like you to use. And so that's what you would do. And below is a list of a variety of those. So when we look at physiologic changes in infancy, the systems are all immature at birth, but will mature generally over the first year. So all of the systems are included, and we're going to see great changes, and we'll have expectations of how those happen. So here are certain things that are happening in the neurologic system. The central nervous system is not fully myelinated at this point. So we're going to see a variance of behavior, but these are generally the times that we would expect. So the step reflex, rooting reflex, sucking, the ability to do those functions will start out in a gross way and then become more defined and more purposeful. So they will move from being reflexive to purposeful. And that's where we're talking about skill attainment. So moving from a gross reflex that we would expect, which is related to the neurologic system, it's just a response, not intentional, to actually taking on purposeful movement. And that will improve over time. We think about the Moro reflex happens, that's a startle reflex. They'll respond to a loud sound or a movement. Their head goes back, their hands and legs will extend outward. And then they will usually react possibly by crying and then pulling everything into the center. So they can cry, sometimes just as the only response to this, and that's still considered a normal reaction. Asymmetric tonic neck response talks about like a bow and arrow or fencing reflex, so the hands going back. And there's a movement they consider crucial to brain development, consistent with that one-sided movement that goes together with the use of eye and hand overall down the line. But so certain of these reflexes are unusual in the beginning, but they're all connected to how that myelinization is going to occur and how the reflexes will become regular purposeful movement. Remember, the plantar reflex it is a Babinski, and the Babinski are tested by stroking the sole of the foot with a blunt object. And their small toes will fan outward, and their big toe will dorsiflex. So slowly coming upward in an upward reflex. An adult response would be just the opposite, where that toe would go in the other direction. Palmar reflex is an automatic flexing to grab for an object, not volitional. Okay, this is just pure primitive reflex. So they first will readily recognize fine motor skill in normal development if unfisting. So the hands are clenched. It's pretty typical, tight in the beginning. We expect to see over time where that hand opens up and is more fluid in its movement. Newborns are going to have that fisted sort of reaction. So we watch and see what happens and how that improves. So you can list or look in your chart in your text. The chart is present and describes these. Here's another group of things to look at. So neck writing, how that occurs, a parachute sideways and a parachute forward. And those are things where the loss of support causes the child to move in a direction, in one direction or another. So these protective reflexes will begin to develop. They are protective. Some of them are involuntary and are required to maintain equilibrium. And many of those things persist throughout life. So just think of yourself when you slip on something wet and you try to catch yourself. You don't intentionally think about that. That's part of that reflexive self-protection to maintain your equilibrium. When we look at the respiratory system, compared to an adult, the infant's nasal passages are narrower. These are important things to remember anatomically because it will affect them when they're ill. So we want to have certain expectations of what we see and what we expect to see. The larynx is more of a funnel shape, and the trachea and the chest wall are much more compliant. The bronchi and bronchioles are shorter and narrower, and the alveoli are significantly fewer in number. It's going to take a while for those systems to mature. The respiratory rate necessarily is fast, and it will decrease as the child matures. And here's an example of what the airway looks like compared to an adult. So sort of a funnel shape is what we call this, right? And look at the proportion. So it's very important, and why the choking hazards are such an issue for children and infants especially, because that airway is small, and we have to be more observant because also they lack any anticipation or consequence. So we need to protect the airway and be vigilant. When we look at the cardiovascular system, the heart actually doubles in size in the first year. The average pulse rate is 120 to 140 in the newborn, as you already know because you've been an OB. And it decreases to about 100 by 1 year of age. Blood pressure averages 60/40 for the newborn and will steadily increase to about 100/50 by 1 year. Peripheral capillaries are closer to the skin surface. The newborn and the young infant are much more susceptible to heat loss. And that's why we swaddle babies and keep them cozy and warm, because their thermal regulation is not mature, and it becomes more effective as time goes on. But that's why we're always wrapping and cuddling babies. For one reason is, keep their temperature consistent. The GI system. So the tongue is very large relative to the size of the oral cavity, and that's to facilitate feeding, allowing for the nipple to latch so the infant can feed. The stomach capacity increases as the infant grows, and so we know with newborns, and many of you have children or have experience with children and realize the difference between the newborn and 2-3 months old versus 6 months old. Just how rapidly the GI system will change and takes on more capacity as the infant grows. And this first year of life is such a period of rapid growth. So we have expectations that things get better and more consistent over time. The teeth are going to emerge in a predictable pattern. So just like I said, these are things you want in the back of your head, that when do you expect them? When should they start teething? When are parents seeing that happen? There are always variances. So there are some children who get teeth early and others much later. But eventually, by a year, most of those teeth have erupted. So it's important to look at the first primary teeth. Those incisors erupt at around 6 to 8 months. So, and that's in preparation for them to be able to eat food. So up until 6 months, we don't expect any nutrition other than breast milk or formula. So no other source of nutrition is necessary or appropriate. Their stomach is not ready to digest food. So giving them anything other than breast milk or formula takes up capacity in the stomach that's really needed for nutrition and is a waste, because there is no nutritional value being derived because their stomach can't break it down. So their stools obviously are going to change as well. So you're familiar with meconium stools as the newborn. That was one of the most important observations we wanted to make, not only for the patency of the GI system, but making sure that things were working and consistent. So over the first year, based on the intake, nutritionally, you'll see the change in the stools as well. Breast and bottle-fed babies will have different stools because breast milk is more efficient than formula. There is, the stools are softer and generally pass easily. With children on formula, there'll be more solid nature that will have a stronger odor. And you have to also be concerned with problems with constipation sometimes. So it's important to be aware of that. As they take on solid food, obviously the bulk of the stool is going to change as well and will reflect some of the things that they're eating. So be alert to those changes as they go. In the GU system, well, the frequent urination capacity is low. All right, the bladder is small. It'll grow rapidly, but it's going to take a while. So expect that to see low specific gravity on lab tests. Renal functions are reduced as compared to an adult. But, and so we need to be alert to the fact that infants particularly are more susceptible to dehydration, but even small children can have that problem. Any change in diet or a cold flu sort of thing where they're off their nutrition or not eating appropriately can make them very susceptible to dehydration. They don't concentrate urine very well as well. So those are the kinds of things that we see and are reflected in the labs. So the integumentary system. In newborns, you'll remember probably seeing lanugo and vernix that's present at birth on some babies. Acryanosis is normal and it decreases over the first few days of life. So it's important to realize, you see that change in color, and, they look like, you know, if they're a decreased oxygenation or whatever, but they just will tend to have that change of color. So they're not truly cyanotic. It's normal to see that, and it gets better in a relative short time. But so when you see that, it doesn't have the same implications as a cyanotic condition later in life. So we expect to see that sort of purpley mottled look in the newborns. And you've been in the nursery, you've been around, and if you have the opportunity to compare that to an infant who's a couple of weeks old, dramatic difference in how the skin looks by color and sometimes feel. So their skin is thinner than adults. Those peripheral capillaries are quite superficial. And so another consideration we always need to remember is that their absorption of topical medications. So it's not appropriate to be using adult medications on infants. And that's a caution we need to give to parents. If we have a young child who's susceptible to kind of sensitive skin and is itching, and the parent wants to put a little Benadryl cream or something on, it's very important the parent knows not to just think they can go ahead and do that, that they only do it under doctor's advice, and that the topical medication is the appropriate one to be used. So again, things that sometimes get asked on tests, like, does it matter or not? Yes, it does. So keep that in mind. When we look at the hematopoietic and immunologic system, the hemoglobin is high at birth. It decreases over the first 2 or 3 months and will stabilize between 6 and 9 months with adequate iron intake. So the maternal source of IgG can be transmitted to the infant through breast milk and help to protect them for the first 3 to 6 months of life. IgM in the infant reaches adult level by about 9 months of age, and IgG levels will reach adult level by 12 months. So even though it starts out quite immature, there's some rapid maturity that will occur that first year. So be alert to how their immunologic system is affected. We're going to talk about the developmental theorists, and these are the basis in this course. And even though these are many years ago, some of them before your lifetime, no one else has described the way children grow and develop any better than Erikson and Piaget. And Freud sort of comes and goes in popularity because Erikson and Piaget just sort of set it out and it makes a lot of sense. So when you're looking at this chart from your book, 25.2, you need to really look at these different stages that are listed and get the sense of them and know when things are occurring. So Erikson uses a philosophy of trust versus mistrust in the birth to 1 year. So caregivers respond to an infant's basic needs by feeding, changing diapers, touching, stroking, holding, talking to them. And this creates that sense of trust in the infant. So sometimes we talk about it bonding. So as the nervous system matures, the infants realize that they are separate beings from their caregivers. Over time, the infants learn to tolerate small amounts of frustration and trust that although gratification may be delayed, it will eventually be provided. And so those things start, whether someone is having the child wait for a feeding, or maybe the parent walks into another room and the child can't see the parent, but the parent will call out to them, and they begin to realize that the parent is there. There is a trust and bond. And remember, peekaboo is a favorite little game that you play with little babies in the first few months. And the reason the child is so delighted when you take your hands away and they see you is that at that point in time, if they can't see you, you don't exist. So then suddenly, you cover your eyes and they, and then peekaboo, and the child is like, whoa, you're there. So it's into that trust that's being developed. When we look at Piaget, he describes motion and action. So sensory motor development from birth to 2, where the infant uses their senses and motor skills to learn about the world around them. So the different substages are, move from reflexive things to intentional. So in the substage 1, the use of reflexes from birth to the first month, which moves quite dramatically from the newborn, and then seeing them, just very shortly after, 2 weeks or 3, you see reflexive sucking that brings not only pleasure of ingested nutrition, but they begin to gain control over the reflex, and they start to recognize the objects, odors, sounds around them. In the second substage, primary circular reactions, 1 to 4 months, some sucking might happen by chance, but then the infant repeats it on purpose to bring pleasure. Imitation begins, so that's kind of the things that we're talking about, how you play little games with them, and just the thing like smiling at them. You smile at them, they'll smile back, and so you get sort of an interaction. Object permanence will start, and the infant will show that affect. So realize that that's what we're talking about. When you cover up your eyes and they can't see you, you're not there. But then they realize over time, it's like, no, they're really there. And that's why a parent can call to the other room to a 3-month-old, and they're like, they're there. Okay, they can't see them, but they are aware that that person is there. In substage 3, we talk about secondary circular reactions in 4 to 8 months, where the infant will repeat actions to achieve wanted results. So they'll shake a toy to hear the noise. They start doing certain movements. They're much more purposeful, but they don't always have an end goal in mind. They just know that when they do this, somebody smiles or it makes them feel good. So they're starting to repeat behavior purposefully. In substage 4, coordination of secondary schemes, the infants are actually coordinating previously learned things from previous learned behaviors. So they may grasp and shake or rattle intentionally, or crawl across the room to get a toy that they want. They can anticipate events. So when someone that they know comes into the room, it excites them, it makes them happy, and they react. Object permanence is fully present by about 8 months of age, and the infant begins to associate certain events like waving bye-bye, that someone's going away, or hello, those actions. At this time, we also see that they begin to recognize who is not in their inner circle. So strangers that come into their environment. And so they're alert to that. And parents sometimes get upset because the baby cries because the neighbor came over that the child's not used to seeing. And they're upset, when actually we should reinforce to the parent that that shows a cognitive function that's expected and working. So that little idea of not recognizing unfamiliar people, is a good sign. So Freud always talks about the oral stage, birth in the first year. So he's fixated pretty much on oral activities related to feeding and sucking. So some things, come and go, but Piaget and Erickson are the ones that have remained consistent. And as we look at that, we look at how all these things happen. There's an upward-outward spiral of development. So infants will be out of sync, things aren't coordinated, and then they sort of fall together, and you've got a routine, everything's working. And then just when the parent gets used to it, it changes again because they're doing the upward-outward spiral of growth. So they're in sync and then they're out of sync. So help the parent to realize that that's an expectation and that it's very normal, and to stick through those little tough times when they're transitioning. And even things like growth spurt. So we know that in the first 6 weeks, we see a big growth spurt and changes in feeding habits. Breastfeeding mothers will notice suddenly the child's had a relatively routine response for breastfeeding, and suddenly they start sucking and wanting to feed more. And it's because they're growing physically and they need more nutrition. And that suddenly is a change. So the parent, that's probably sometimes the first time the parent's really aware of how those cycles are changing and how they are changing and increasing their ability. And so people who are doing lactation support need to be alert to that and help the parent realize to anticipate that, because sometimes they'll have problems managing their breastfeeding during that time. So again, those are reasons we want to know what happens when, so we can give anticipatory guidance to our patients. So motor skills that we see happen, and social emotional growth. So it's pretty important when we look at that stranger anxiety that I talked to you about, and they see themselves as separate from other people. Separation anxiety occurs again in later infancy, and that relates to an infant being distressed when the parent leaves. Children who have that in their normal day-to-day routine, parents who go back to work earlier, the child will go through this period in one time or another. But children who tend to be home with caregivers and are not used to not having them around will be quite distressed when the parent leaves, but they'll begin to transition and understand the parent will return. We also look at the temperament of individuals. Right? So remember that parents will be a really good measure and descriptor of how their infant is. So they'll say, my baby's really quiet, or this baby is really active, and wow, he's different than the child I had before, or whatever. And so they'll talk to you about the way the child acts. So that is their temperament. How do they respond to the world around them? And what is their tolerance level? So it's important to realize that these are normal expectations. That's what's happening. And that's how we help parents to move through that. When we look at motor skills, it's very important to remember how they develop. So gross motor skill development is cephalocaudal, which means head to toe, right? Okay, or top to bottom. Fine motor skills will develop in a proximodistal reaction, okay, from the center out. So remember, gross motor versus fine motor. That's the expectation of how they will develop those skills. And this is a good chart to look at that and things that we would expect in the gross motor skills. So in the first month of life, the child is learning to lift and turn their head when they're prone. There is a head lag. So if they're sitting in your lap and you hold their hands and then you pull them up, the head will lag behind. By 2 months, they're able to raise the head up to the chest, and their head control is improving. 3 months, the head raises to 45 degrees in prone, and then with just a slight lag. Whereas with a newborn infant, it's like way back, it's not going anywhere. But it's by 3 months, they're starting to bring it forward and being purposeful at keeping in the core. 4 months, we see that they lift their head, they look around, they're rolling. So we want to anticipate that with parents for safety, that not leaving them out of arm's reach or in a safe place, so that if they do roll over, that they're safe. And 5 months, we active rolling from supine to prone and back again. And they'll start sitting upright with support. So they have lots of fun little baby things that people buy, for presents and stuff. Kind of, I don't know, there's a funny pillow. It's like shaped like a C, and you can put the baby in it. And so they kind of slide this way, slide that way, but it's keeping them upright. And the more upright they are, the better. It's helping to develop the musculature, and it also helps with feeding. One of the biggest challenges for babies in that first couple of months is learning to coordinate their sucking and feeding efficiently. And so during that rough time where they're moving forward, they're not always real efficient. So they swallow a lot of air. And so why do we burp babies? Most of that burping of babies is usually, under 8 months, because it's when they are less upright on their own. And so the musculature of their abdomen and their chest is not well developed. So as they get more upright, that musculature supports that movement. So those air bubbles will start to move themselves. They don't always have to be physically burped to get that sort of air to come up. And it's important for parents to know sometimes when baby's feeding really well and then they just slow down, that's a good clue for them to take the baby and sit them up and burp them. And it's hard because when parents are worried about, am I feeding them enough, whatever, they're like, as long as they keep sucking, I want them to do that. But once they sort of slack off or act disinterested is the time, because the air in the stomach, as well as their nutrition, is giving them that sense of fullness. So they slow down. But it's important to get those bubbles up, because if they overfeed without burping, then they're more spitty. Okay, and we know little babies are always kind of spitting up in that first 6 months when they are less upright on their own. So the things we can do to encourage good feeding habits and facilitate overall nutrition is to remember that burping is as important as the feeding, so that they don't lose that nutrition because they burp and regurgitate too much. So, and parents will describe their children as, he's always really spitty or not, that sort of thing. So some re-education about burping and being patient with the feeding, because sometimes they're in a rush, they just want things to happen. Helping the parent to be consistent in that approach is always very important. So keep that in mind when we're looking at that gross motor development. Here's another chart of skill progression. So we talked about them starting to be upright and, with support. And then as they start to support themselves, tripod sitting is where they have their hands in front of them. And they're actually, relying not just on their legs and hips, but also a little support from their hands. They start to sit alone, some use of hands, but much more able to sit alone and even like reach for things or look somewhere, because they're unsupported between 7 and 8 months. So we start to see that, and then movement. Now, some children will be earlier than these, but these are the expectations. So you will have known infants who do them earlier or later. But remember, for the purposes of this course, you want to keep these parameters in mind. 9 months, we expect to see them starting to move on their own. And so the belly, kind of being on their belly, and belly time is important for them because they're not allowed to sleep on their bellies like babies used to do many years ago. We don't do that. We have them on their backs to sleep because of the risk of sudden infant death. And so it's important that they get belly time when they're awake. Putting some objects out, putting things on the floor where they can go and reach for, and that will encourage them to move toward an object, making it interesting so that they'll start to crawl around. So they tend to be sort of a commando thing on their elbows, and maybe not with their knees up at all in the beginning, but just kind of crawling along on their belly and using their arms to pull. They will get better, and we'll then see them start to pull themselves up to stand, that cruising. And that posture, and a lot of parents think, oh, my baby's not going to crawl because now they're walking around the coffee table, sort of thing. But really, it's sort of the opportunity to stand up and see what's out there, to say, oh, okay, I think I want to go get that. And so they will go back down into the crawling position and spend time crawling before they actually are going to walk. So by a year, we expect that they have the ability to sit from a standing position, and that they start to walk independently. Some children will be a couple months later. Some children will be walking at 9 months. So help the parents realize that it's all within the normal range. make sure that they're not overly anxious. It's tough because they have family and friends and other people and other comparisons, even other children with this child. And so then they begin to worry that they didn't do something right or that there's a problem with the baby. So reassure them that this is a range, that they all will get there. And that will help them focus on what the actual actions are. So we look at fine motor skills. You can see, again, that progression that's going to occur. So the fists are clenched and there's an involuntary, the hand movements are just kind of flailing a bit. By 3 months, they've got their hand in front of their face and they will open their hands purposefully and look at them. Then they'll start to actually use their hand to reach or touch something. And then between 3 or 4 months, we see them grasping. So they're purposefully holding onto something. And so it's very easy to do certain things to just encourage that behavior. Things like putting something in their hand. And it can be a rattle or a small toy or even like a spoon, a baby spoon. So they start to get used to that because eventually they're going to use that spoon to feed themselves. So if they start building some dexterity, all those things are positive. When we see them at 6 months, then we see that they release an object in their hand from one to the other. So they're going across the midline. That's important to see because knowing the midline, having a conceptual or a sense of the midline is going to be important down the road for reading readiness, because they have to be able to do that in order to read. When they're transferring objects from one hand to another, it's very common to see them do that. So these are those fine motor progressions that we look at. Here's some more continuation of the fine motor. So that pincer grasp where they're reaching for things and pulling it toward them. Then they start to use the objects together, like banging them, making noise, realizing they get a reaction or a sound, and so purposefully doing those things. At 10 months, their fine pincer grasp is improving, so they can put objects into a container and take them out. So they're getting very busy and using their hands. And then 11 months, seeing them being able to offer it to someone else, letting go. So when it's early on, they don't want to let go of the object. They might want to show you, but they don't want you to take it. By a year, they can feed themselves with a cup and a spoon, and they can mark on paper. And that gets real important to, what kind of things you have around to let them mark and mark on. And they can poke with their finger as well. So they're developing that use of their hands, that grasp. Now, remember that the gross pincer grasp and fine motor grasp are going to continue to evolve really until about 7, where they'll reach about pretty much the ability of us, the adults, to open and close things in that grasp, because you can do the object, but then you have to be able to do it with certainty, with firmness, with force. And that's why when we look at car seats are developed, and as a grandparent, it's really frustrating for me, but even for parents to be able to get them in and out of car seats. And actually the clips on the preschool and school age chairs tend to almost be a lot stronger. And it's because we don't want the kids coming out of the seat on their own volition. We want to snap them in and make sure they stay there. They're able to snap things together before they can undo them. And that's the undoing is what we're concerned about. So you'll see them, having difficulty getting out. They can learn to snap in, and they love being very capable, and we're going to encourage that. But it's important that we realize, why can't they get out of the seat? Well, we don't want them to, but many times they do. So that pincer grasp is still evolving. Children with neurologic disorders will have delays in those pincer grasps and may actually have goals at school in learning how to do the pincer grasp and to be able to function using things like snapping themselves into a car seat. So be aware that there's quite a range in that movement. So there's a question here. The following statement is true or false. Fine motor skills, remember fine versus gross motor, develop in a cephalocaudal fashion from head to tail. Think about that. And of course it's false. Fine motor skills develop from the proximal distant fashion, from the center to the periphery. So gross motor skills develop in the cephalocaudal from head to toe. So when we look at premature infants, we have things that we need to think about. So it's really important when we're measuring them over time and when we follow them, that the level of immaturity that they have when they're born sometime before 36 weeks gestation will indicate differences in their ability to attain certain skills. And so we will have a different expectation of their developmental movements and actions. The problems that are incurred with prematurity put them always in a risk group. So that anytime you're saying, what are the risk factors or who are the risk group, preemies are always going to be in that group. Significantly immature respiratory system and nervous system. Because we look at, see how quickly that nervous system develops in the first few months. When you have a child who's, more than a month premature, they have not had that final opportunity to sort of, get themselves ready to go. They don't have the same iron stores. Their immunoglobulins, again, are mature. Their intestinal GI tract is not capable sometimes of oral feeding. They may not even tolerate enteral feedings. So that can be very critical when we're looking at how we treat them and how we help them develop. So we want to also know that we have to adjust for prematurity. So when an infant is born prematurely, so if they're at 34 weeks or 32 weeks, here are examples that we'll talk about. We're going to have different expected outcomes. We'll plot growth parameters and assess developmental milestones based on their adjusted age. So to calculate it, we subtract the number of weeks the infant was premature from their actual chronologic age when they were born. So an example of a six-month-old born at 32 weeks, we would take 6 months minus those 8 weeks that they missed in the uterus, all right, 4 months. This infant's growth and developmental skills should be that of a 4-month-old. So those grasping things, movements, the upright posture, all of that, we expect that there will be or may be delays related to their prematurity. So we don't, over anticipate. And we have to help the parent to understand that too, is that time lost in utero will take a very long time to make up. I've talked to some parents of children who are preemies and they're 14 years old and the mother's like, he's almost 6 foot tall, but he acts like, 3 years younger. And so it might not be in physical activity, but it could be in emotional or social development as well. So realize prematurity is that risk factor that kind of lingers on through childhood. So here's an opportunity for you to, again, to do that calculation. The nurse is assessing a 7-month-old born prematurely at 28 weeks. What would be the adjusted age upon which the nurse bases their assessment for infant growth and developmental milestones? So 7 months premature. So here we are, 4 months. The nurse assesses developmental milestones for a 7-month-old preemie born at 28 weeks and adjusting it to 4 months of age. So that's a big difference. And as we saw in the movement and actions that happen between 4 months and 7 months. So help the parent to understand to expect that those things may occur, and not in every sphere. So sometimes physically they're doing well, emotionally they're not doing well, or language, different things. There may be variances that will be unique to that individual. So it's important to have the expectation that it may be less than, and ways to encourage the movement toward the actual age appropriate. So when we look here, early warning signs of things that we need to always be alert to. So we want to remember that vision and hearing are critical to how we take on the world around us. So the little hints and things that when you're talking to parents about how the child is, how they're acting, and your interactions with them. So how do they react to loud noises, or do they not? Are they babbling and talking to themselves? By about 4 months of age, we expect them to be making sounds and talking to themselves. Not turning around to locate a sound. So something happens behind them, and we hit the table, and they don't turn to look or investigate. Vision. Now we do have eyes that cross. That's expected in the very beginning, because remember, the eye muscles are like a figure 8. So you've got all these muscles working to coordinate not only one eye, but coordinate the bilateral ability of the eyes to work together. So we expect that there will be some lag in that at the very beginning until they have practice of moving their eyes. But we would expect them to have their eyes forward and working together, having the ability to track. And that's just taking a fun little toy or object and moving it across and letting them, seeing if you can get their attention and have them follow it. So, and if they're not looking at things that are close to them, because maybe we'll stare at things and start to use them or interact with a toy or something around them. And so when we see those things not happening, we want to investigate that further. Very important to realize that these are things that some things that parents may bring to your attention. Say, he doesn't get upset if something falls on the floor, or he doesn't seem to notice things like that. So, or the eyes are crossing a lot. It's really hard for the child then to visualize and to understand what the world around them is like. So it's really important to look at these cues and investigate further. And you see this child with these little earphones on, they can actually do, it's amazing now that we can check their hearing by measuring response in the brainstem. So we don't even have to have a voluntary response. Over time, as they get older, we'll do play audiometry and continue measuring hearing, and we'll do more traditional measures like we used. So warning signs with language development. They don't make sounds when you would expect them to. That's really difficult. So by about 4 months of age, we talked, remember, like I said, we would expect them to be babbling, talking to themselves. They laugh, they make sounds, they squeal. Not doing those by 8 months of age is cause for concern and would need to be evaluated. So the child is just more than super quiet. Those are things we want to see. Can we elicit a response? Sometimes the environment has not been promoted around them. The child may be, in an environment where they don't get a lot of stimulus. So they may be left to themselves, and so they don't have interaction. But generally, even those young infants are making sounds because they're interacting with themselves. So if they're not using words with meaning by the first year of age, like typical things, mama, dad, again, we would have concern. And we want to know whether it's actual speech development or whether there's a cognitive issue. So things to think about and be aware of. When we talk about breastfeeding, that decision to breastfeed is heavily influenced by cultural expectations. It is the best nutrition for newborns and infants. And there are many health benefits, as we've outlined before, for the mother and the infant. But it requires correct use of techniques for success. And that's why we have lactation consultants that are readily available to parents. And those things are ways to support and promote breastfeeding. The benefits, again, for the mother, the bonding, immunologic protection, possible enhancement of cognitive development. And that's because there's a lot of eye contact that's going on when the child is close breastfeeding. Decreased incidence of obesity later in life. And that's considered that they're getting very proficient nutrition. And so that encourages, good outcomes. The decreased incidences of diarrheal diseases, allergies, asthma, otitis media. And remember, anatomically, the ear canal of an infant is sort of horizontal, whereas as they grow, the ear canal will tip and then drain naturally. So they already have problems as being young and having that anatomic difference. And then if they've been fed and allowed to have the bottle in bed with them or any of that, then you have drainage sometimes of formula into the ear. And that's a highly nutritious fluid. So, the sugar, that sort of thing going on, causing ear problems, earaches, ear infections. Bacterial meningitis is cited as a possibility. Botulism, and that relates to proper handling of the formula, and urinary tract infections. So these are the increased and decreased, incidence of things that we want to look at. Bottle feeding, there are multiple types of formula available, and they can accommodate most nutritional needs. And so if children are particularly sensitive or allergic, they'll come up with the right formula for that child. Most of them have the essential vitamins and minerals, obviously, but very important, and more so in third world situations or transient situations, which of course we have a lot of, is that they are putting it together appropriately, using not only the package directions, but the right volume of water and also clean water. So we need to know that the water source is good, and clean bottles and nipples. Pretty difficult if you're living in a car or you have one bottle, that sort of thing, really, really difficult. So we want to take the circumstances into consideration when we're looking at that. And that's why, especially in, more transient populations, we want to encourage breastfeeding. It gives us an opportunity to feed the mother well, to help the bonding with the infant, and to reduce some of the hygiene or, cleanliness issues related to the delivery of nutrition. So keep that in mind. That's why we had lots of problems in the 80s when powdered formula became the rage. That was, that didn't happen until about then. And we had formula companies selling to third world countries without good sources of water. And we saw a rise in infant mortality because they went from the mother breastfeeding to using this formula. So two things happened. When they were breastfeeding, then they were being offered food so they could produce milk. So mother and baby both, benefited. When they brought in the formula, they stopped or decreased the amount of nutrition to the mother. So then they became malnourished, and the infants even more so because of the fact that now we had formula being used, not always reconstituted appropriately or cleanly. And so mortality rates increased. But it was a lot of, I won't say political, but, these heads of countries, most notably a man called Idi Amin, who bought into that whole thing because they were paying him off to do the formula. So, and the mothers and babies did not benefit. So promoting healthy eating habits is important. We always want to remember that. And we want to remember that children should be fed on demand. We don't want a prescribed diet that they have to have so many ounces or so much of this. We want to give them the option. And little children will eat what's appropriate for them and do well. And best not to force them, but realize that they also have sort of a posture of being what we call grazers, where they'll, when they're eating, once they start eating solids, is they'll eat a little bit at the table with you, but they don't clean the plate. You know, they're too busy with all the interaction going on around them. But then by the time, you know, so they won't eat, you let them go, and you're cleaning up the dishes. By the time the dishwasher is ready to go on, they're back, and I want something to eat. So we teach parents to just don't empty their plate, just put it on the counter, leave it for a while, because they're likely to come back and then continue to eat. So when we talk about when to start feeding, 4 to 6 months is when we start to promote, you know, taking in food. So the easiest thing to realize when they can take solids is when their tongue extrusion reflex disappears, the sucking reflex kind of thing, where they can swallow like, and they take on swallowing like we swallow. So you still always start with small amounts of soft and mashed up things because they don't have teeth. But you'll be surprised that even children without teeth can take in amazing things. I used to watch my granddaughter, who didn't get any teeth until 8 months, eat a piece of pineapple. What she did is she just kept sucking on it into shreds, and little pieces went down. So there's no choking hazard. She's given a piece big enough that if she put it in her mouth, it wouldn't go anywhere. But she would generally just suck on it until she just sort of wore it down little by little. When you're introducing foods, those of you who've been parents are aware of all these little pieces of how to do it, and share that with those who haven't had that experience. But one new food at a time, wait 3 or 4 days, because you want to just be sure that the child doesn't have any sensitivity or allergic reaction to the food. We always want to do vegetables before fruits, and especially when we're feeding them, because think about it. Have you ever like had orange juice at breakfast and then you have a bowl of cereal? You know, you can't like go back and forth between the bowl of cereal and the orange juice because your mouth is saying, whoa, what happened? Okay, so that reaction causes the child then not to want to eat vegetables or things that weren't as sweet as the fruit was. So it's important to take your time, have parents take their time when they're introducing new foods. There's no rush. It's not so much about nutrition in the beginning. It's really building the right habits, knowing what the menu is of what you have available to offer. Introducing the cup early. So in the beginning, even at 4 months, when they have that grasping behavior, you have the little sippy cup, you put an ice cube in it, put the lid on, and let them have it. It makes sound, it's like a rattle. And when they learn to put their mouth to it, there's only drips of water coming. So they're not going to get a gush that's going to make them choke. So start getting them to manipulate the feeding tools, the spoons, the cups, all those things early before they actually are using them, and then introduce the food into them so that they take it on very naturally, and it's very acceptable. And many breastfeeding mothers move from the breast to the cup and avoid having bottles at all, which is really nice because bottles, you know, just have a whole lot of work to them. So you can encourage that with breastfeeding mothers and say, if the child is doing well in the breast as they take on food, offer them that sippy cup, getting the child, and they're interested in it because, oh, you know, there's something in there, it has a taste, and, you know, and they'll dribble it and make a mess. But that's why, again, you put small amounts, and the going in the car, same thing, you know, make it, you know, like with ice or something in it where it gradually will melt down. So there's not this whole gush of liquid until they become more adept at swallowing. So modeling behavior from how people eat in the family. And when you do it and smiles at, good, okay, the child wants to model behavior. Children are looking at the expectations from you. They want to please. So even when there's feeding problems, those kind of things, the parent should be directive. Help that young parent, especially new first-time parent, understand the child is waiting for them to tell them what to do. And so they need to take that on and give them some confidence to do it. It doesn't always work, but you're the mom or you're the dad, you're in charge. And so you smile when they do it, even when they're a little not so sure. It's like, oh, it's good, try it again, you know, sort of thing. So it's the way you provide the food to the child that will help them decide what to eat and how to do it. So some of the kind of things we want them to remember. Next, we're looking at the cultural influences, which can be many and varied. And we know that we live in a multicultural society. We see a lot of variances around us. So take into effect those cultural practices. What is the parent used to in their family environment? What have they been taught? What is typical? And then also take into account parenting styles and ways to promote healthy nutrition, healthy sleep, activity levels that are influenced by culture can be very positive. So help to translate those things into a healthy lifestyle. There are some common developmental concerns in infancies. As I mentioned, the spitting up sort of thing. Colic is kind of an odd little thing that only happens for a couple of months and usually lasts 3 to 4 months. And so we look at ways to sort of reduce that. And baby just is, you know, crying with belly pain sort of thing. And it becomes exasperating and tiring for the family. Child doesn't sleep, he's crying all the time, wants to be held, doesn't want to eat. So we look at things like offering a pacifier, seeing if that will help. Sometimes white noise, gentle rocking, just certain behaviors that help to move them into a soothing, more relaxed posture. Sometimes, especially if it's been going on a while, it's important to have somebody who can take over. Maybe a babysitter, maybe a neighbor, someone who's just like, can you give me an hour? Let that parent relax, come away from the baby, not be listening to the sounds of the crying, and then be able to, you know, kind of sort of take resolve and come back and be able to take it on. So sometimes children do have digestion sensitivity, or they react to the mother's diet, especially, you know, the breastfed babies. So the mother should be taking into account if she's breastfeeding, what did she eat recently? If she's seeing a sudden change in the baby's reaction, where it looks like they're getting belly aches, then maybe there's something they've eaten that's affecting the child. So that's easy enough to correct. That upright posture that I talked about for like the burping, same thing applies here. Keeping them more upright in a little car seat or a carrier will just allow, again, air to come up while food's going down. Again, spitting is considered normal, and we always keep children upright after feeding. Over time, as I said, that musculature matures, and so then they're able to tolerate what's going on. When they start teething, again, remember those teeth are going to start erupting between 4 and 6 months. So even a month before that those teeth are moving, and so it may be a little itchy, twingy, you know, twinge sort of thing that the child's feeling, but they're going to want to suck more, and it's good to give them things to just sort of help to calm them down. And there are lots of things. There are little teethers and things that sometimes you put them in the refrigerator. And again, don't put them in the freezer because that's like too cold, but just being in the fridge is enough. And something cool is all they need. And they like also to be pressing, a little pressure. So another thing to consider that works well is those little mini bagels. They're about this size. And what you do is cut them in half like a C, okay, not in half like you're going to put, cream cheese and eat them, but keep that outside whole. Remember, bagels have sort of a tough exterior. So other than like teething biscuits are sort of like a mess. All right. They just make goo and then things get stuck and dried on, and it's like a nightmare for the parent to keep cleaning up after. The bagels are simple and easy. They, you can put them in the freezer and then bring them out kind of semi-frozen, just because they feel cool on their gums. But then as they defrost, they're going to be spongy. So they're pressing on it, and it gives them comfort to have some pressure. So that's a way to sort of help with the teething issues. There are also other things, that can numb their gums and stuff, but, when you can just use simple things, it's sometimes easier to take with you. So when we talk about healthy sleep and rest, newborns and infants are placed on their back to sleep, as we know, to decrease the risk of SIDS. And you learned about that in OB. So if you need to read more about it, you can look at your textbook. Remembering that newborns will sleep up to 20 hours a day. All right. They only wake up to feed, and, you wake them up to change them. So it's, they're barely down and they're up again. By 3 months, they're sleeping 7 or 8 hours at night, we would hope. Might not be. And they take 2 to 3 naps per day. So that's an expectation. So you want to help the parent to be able to transition that child to that kind of behavior. So having a sleep posture is what encourages to put children down, not to have to rock them to sleep or do that, but to create an environment that helps them relax, make predictable sleep times, and this will be consistent over their lifetime. So if you can build those healthy sleep behaviors early on, the children will take it on, and there won't be the conflicts, because that becomes a problem over time. And all of us have grown up in families, so we know how we did, how hard it was to go to bed when you didn't want to, that kind of thing. So it's starting early, with newborns. And so there are different measures. BabyWise is a common reference that parents use, and their posture is to just quiet yourself, and then you help quiet the baby. So you change your normal behavior with them, not bright-eyed and ooh ah, talking, interacting, but soothing, not always making a lot of eye contact, but cuddling and being close, but humming or using a little music in the background or white noise, so that you create a restful environment and getting them relaxed so you can actually put them down without their being asleep, but they are relaxed and ready for sleep. So the way the mother rocks the baby, whether they're in a rocking chair or whether, more commonly today, we see women, taking advantage of that as an opportunity for a little postpartum exercise, doing deep knee bends and swaying or moving their bodies. And so they can do that in a soothing way to help their infant while they're helping themselves feel better as well. So it's that relaxing, predictable sleep time, so that even later on, as you put them down for naps, you read them a story and you say, I'll see you later. And the child is ready. They know it's nap time. They expect it, and they find that it's not a hassle. They are ready to sleep. So looking at the number of hours. So by a year, they're sleeping 8 to 12 hours at night, and they usually take 2 naps a day. And children will be quite variable on the naps. Some do 1, some drop their nap soon, but usually a morning and an afternoon nap. And the length of the time will eventually shorten so that they may only be in kind of a quiet, relaxed state when they're 3 or 4. So they spend time in their room and they're permitted to read a book or do other things, but there's an expectation that they will rest themselves for that period of time. And it's a good measure to talk to parents as to how their children are reacting overall. When children start to get cranky and they're oppositional, the first thing the parent needs to think is, what was the sleep like yesterday? Did they go to bed late? Did they not take the nap? And so as they transition out of naps, there'll be days that are good and days that are bad. So when the child's getting cranky or oppositional, you say, you know, you didn't have a nap today. So why don't we just go over here and sit and read a book and let's just rest a little bit, because I think your body needs a little rest. Don't force them to take a nap when they're all excited and cranky, but make them aware. I need to sleep. I need to rest, be myself, and not be cranky or oppositional. And so when we start seeing those toddler behaviors and the preschool behaviors, those things can be avoided by just looking at the sleep habits. And parent needs to take responsibility that the child gets adequate rest. So if they're disrupted and they don't get a nap, if you're on, travel and that didn't happen, find a way to make it happen once you're in a place where they can rest, or bring them to bed earlier so that they will start to make up some of that sleep. Pretty important. So promoting safety. All right. Well, we all know that there are lots of rules about car seats. California has its rules. So I would like you to look at what the California rules are on car seats, know what the correct type of car seat is, how to position the infant in the seat, and securing the seat into the vehicle. So it has to have a tethered strap. It should be bolted to, a bolt that's in the car frame, not just pop it in the back seat and throw a seatbelt across it. That doesn't work. So, especially for infant car seats. So we want everything to be safe for them and age appropriate. So always think about that. Baby walkers, they are discouraged highly. You'll still see them around. And it's important to realize there's a difference between walkers and there's like play yards where they can sit in something, but it doesn't really move. That's different. But the things where they're walkers, the problem is that it lets them be places that are inappropriate for their age, where they can reach cords or, curtains or any kind of thing like that that could become unsafe for them and pull things down on them. So that's why baby walkers are discouraged. Safety gates, outlet covers. Remember when you are child-proofing to be age appropriate. So sometimes even on a test, they'll ask you a question of the child is this age, and these are the things you need to do for child safety, baby proofing in the house. And so they'll throw something in like, cover those outlets. And they're talking about what's the safe thing for a 4-month-old? Well, is a 4-month-old able to access those plugs? Not likely. So you don't have to put that on. This might be nice to just do it all at once, but what's age appropriate for that child? Age appropriate. So it's based on function. So that's why we talked about that motor movement and things. So what can they do? What we're expecting. So then we make our expectations and parameters for safety to go along with that. So we're not worried about bike helmets when they're 8 months old because they're not on a bike, right? So just keep it age appropriate. Identify and avoiding choking hazards. And that is really difficult because children are everywhere and every kind of little thing can come at them that you don't even think about. A bottle cap, things like that. So different foods and how they're offered. So very important to realize that what's appropriate. Like you could give a 2-year-old a potato chip because if you put a potato chip in your mouth, it will melt. Okay, when it goes down, it's soft. You would never give them a tortilla chip because even adults have choking problems with tortilla chips. Okay, they're not going to dissolve. They're not going down soft. And so they are not an option for little kids. When you're serving nachos at the football game, make sure you have within the child's reach something that's appropriate for them, making sure adults are not offering things that are not appropriate. And that's where those sort of little subtle things can happen and cause a problem when, people just aren't thinking. So it's real important to realize that. Water safety. So even just around the house, the bathrooms, all right, they love playing in the toilet. They fall in the toilet, falling in head first is can be a real problem. All right. Buckets and tubs. Okay. When they're in the tub, they need to be within arm's reach. You don't put them in the tub and go away. You're in the room with them. So you can snatch them up. If they slip and fall, bang their head, go face first. So you want to be able to snatch them right back out of that water, calm them down, and not make it a traumatic or dangerous event. So it's really difficult on some of these issues, and it's important. And families with multiple children will sometimes be a lot more relaxed about that. They just need to be alert to, how are they managing the safety issues that are age appropriate for the children. So they should never be in the tub alone. It's just not appropriate. Age appropriate toys. So that's hard too in families with a lot of children, because we all know Legos exist. And most of you have probably had the uncomfortable experience of stepping on a Lego in your bare feet, and they're awful. So imagine what happens when they go into someone's throat who's too young to have them. Because those teeny tiny Legos get really teeny tiny. And so when older children have them, they have to be in a place that's not accessible to the infant. Sorry, I'm a little dry. A lot of talk. So keep that in mind, that the age appropriateness, and especially in families with a lot of children, so that the older kids' toys are not accessible to the younger kids' toys. And you can say, oh, their room's off limits, but we all know what happens. And we all know those little Legos kind of creep out of that room, and they're in the family room, or they're in the kitchen, or wherever, and they're always falling on the floor. So it's important to help the older kids understand why, and that's why you have baby Legos and older kids Legos. So safety is always an underlying concern in all that we do. So we want to not only promote it, but be alert to the issues that can cause problems. So that was a lot of information, and I appreciate your patience, and I hope that you have gained some new information. And I know, and it's sad to say that we don't have the opportunity today in a pre-recorded lecture to talk about instances or things that other people may be able to share. And so we will, when we're together and when we're live on Zoom or in a classroom, talk about some developmental things. So if you have any things that you think are particularly helpful, please feel free to do that, and share with your colleagues and share with us when we're together again. So thank you for attention. There are 2 more chapters for week 1. So I am going to pause this and make a separate video for each chapter, so you can look at them individually or together at your choice. So see you at chapter 26.